welcome you to tonight's evening where we're going to talk about how to be successful with implants. And these types of ridges are not a coincidence. They didn't happen by mistake. There's a specific protocol that a periodontist or an oral surgeon can use to build up a ridge that has enough bone and soft tissue. That's the key. Plus, precise implant placement, tissue management, excellent restorative work. I think this is Dr. Schwartzman's case. The key here, like anything we do, is not to improvise. It's a clear protocol that works, and I'm lucky to have learned a lot from Dr. Rosenblatt. I'm lucky to pass on some of what I know to my students and doctors that visit with us, whether it's a single tooth replacement or full arch. It comes down to a protocol. And if you have a protocol, you're not improvising and you'll get predictable results. And I haven't done all of this by myself. I work with great restorative dentists, prosthodontists, other specialists that help us achieve some of the results that you'll see tonight. And I'm extremely lucky to be seeing people that I enjoy being with, like Ari, like Alex, like Lloyd, and our team. And from Ari starting our practice now 46 years in 1980, till today, I mentioned to David here, we are a legacy practice, but a legacy, we got to work every day to prove that we deserve to be there for 46 years. So we don't take it for granted. We appreciate how all of you trust us with your patients and with yourselves. A lot of you came as patients and had some of these procedures, so we appreciate it. Starting with Ari, I met Ari in 2003. I was living in Toronto. He needed an associate. I came, make a long story short. I started working for Ari. After 5 years, we became partners. And Ari is going strong. When you work with Ari, you know that he's always there. He's going to pick up his phone, even if he's on a vacation in Italy. He's going to answer the call. He's going to send you the text message. And not only is he a very gifted surgeon, he's a gifted human being. He's a class act, and Ari, I'm very fortunate that I've met you, and a lot of the things that I have achieved, I feel like are thanks to you. So thank you very much. And thank you for mentoring me on how to run a good practice and all the systems and the protocols, and for mentoring our associates like Dr. Alex, incorporating laser technology. Obviously, I'm not going to talk a lot about myself, because I don't do that, but what I bring to the practice is education and new technologies that I think will help us provide better treatment, that will bring us better patients and better referrals, and some of those technologies I'm going to share with you today. Then we were joined by Dr. Lloyd about 2 years ago. He brought a very important aspect into periodontics, which is holistic or integrative periodontics. I call him the periodontal surgeon hacker, so biohacker, and he brought the Zirconia implants. He's going to share some of what he does in the office as well. Plus, he brought in a whole element of health, of wellness, that includes different types of testing, genetic testing, biome, etc. So, and ozone. So thank you, Lloyd, for bringing all of that. And then there were 4. And Dr. Alex joined us, and she brought her own set of skills and personality and a winner mentality and new technologies where Ari, Lloyd, and myself are learning how to do things in a better way, and Alex will share with us some of the things that she does in the world of sinus lifting, or mostly minimally invasive sinus lifts. And together, it's fun to practice. I wish we could be together, all 4 of us, every day. It just doesn't work like that. By the way, this photo is not staged at all. It's all spontaneous. And other than that, I hope you enjoyed the evening. So the difference between these 2 types of images is A protocol. It's a system. If you follow a protocol, you have a high chance of predictability. If you use techniques that preserve ridges, where you have good soft tissue management, we have good vision of the restorative aspect of treatment, you're going to get better results, or you have a better chance. Especially when it comes to full mouth rehabilitation and full mouth implants, everything matters, from the patient exam to the imaging to the planning, and I'm going to share the protocol with you and how we plan these cases together on a consistent basis. It's not a one-off. Every case in our practice follows this protocol. Now, this was not always like that. If you remember, for the ones of us who started around 2000, 2005, what happened back then in regard to implants, it was the implant gold rush. Implants are obviously very lucrative. There's a lot of money to be made. And the gold rush, as we all know, was get as much as you can, place as many implants as you can, make holes in bone and fill it with titanium. That was the approach. And like in the gold rush, a lot of bad things happened. There was a lot of crime. There were a lot of bad things that happened because everybody was looking for that gold. It was that bad that Dr. Ryman here and I started a program called the Implant Gold Rush. That was a program to teach dentists how to practice implant dentistry and surgery at the time of chaos. Because chaos many times brings opportunities if you identify the problem. So what happens with this gold rush, we started to see in the community, in the nationally and even internationally, more failures, more aesthetic failures, more peri-implantitis, because doctors were just slamming those implants in, and some still do. And that, to each their own. And this is not about shaming anybody, but this was how it was about 20 years ago. So this is, Rashad, this is like an old program, the Implant Gold Rush. This is for real. It was actually very successful because it was teaching dentists how to practice not in a scarcity mindset, not to just place as many implants as you can, but do it at a high level and be able to be even more successful. So it's like winning the gold rush. When I see implants that are in the second molar position and are facing the cheek, this is an impossible restoration. It's impossible. No angle correction is going to solve that. And that makes me really sad as an educator that cares about dentists. My whole life is about dentistry and dentists and doing dentistry. When I see implants that might be avoiding the nerves, although there was some nerve damage in this case, and each implant is facing a different direction, not to mention the soft tissue. And again, it's not about shaming the dentist. I actually feel very sad. I have sadness in my heart. I'm serious. I'm sad. Because when I see this case, I know this dentist is going to be sued badly, and there's no way to defend this. I want to take this dentist, and I want to take him or her. I want to take him to my practice. I want to show him what's the right way to do implants, and we don't have to say yes to every case. Certain cases we got to avoid. Like this case, if you don't have enough bone, either you can graft it or not, or just say no. It's way better than doing what we're seeing here. So what I want to share with you in a short and concise way, and I want to take about 20 minutes, if I can, to talk about the modern implant protocol. It's pretty simple, and it's pretty simple to understand. Like every good story, it has three parts. Part number one is the planning and the communication. Part two is the execution. That's the fun part. That's the money-making part. And part three is verification, making sure that our treatment was successful, and healing optimization. I just want to get a understanding of, I want to give you a big picture, high-level overview. So we're going to start with part one. I'm going to share with you the principles of the modern consult, the virtual planning and the communication. In part 2, I'm going to talk about the anti-collapse extraction strategy, how we preserve the ridges, how we execute our cases. I'm not going to talk about full arch so much. That's going to be for a different lecture. And how we customize healing abutments. In part 3, I'm going to talk about how do we verify the implant integration and how do we optimize healing. The modern implant protocol applies to full arch, which I'm not going to get too much into the detail. We are, Rashad, Dr. Roxanne, and Rafi, we are coming up with a book called The Big Implant Case Manual. Everything will be in there, so we'll share this when it comes. But the modern protocol applies to full arches versus single implant cases. Starting with part 1, let's get right to it. Planning and communication. As periodontists, as surgical specialists, we always keep in mind that the implant is not the goal here. The goal is a restoration. There's a restorative goal with a surgical arm or a surgical method to get the restoration where it's supposed to be, and that's what's going to dictate the implant positioning. So we take all the measures that we can to figure out what's the vision. That's where you create the vision for your case. The concept of same-day consult and surgery or consult and implant doesn't work well. It's just a recipe for disasters, and it just never worked for us. So the consult is extremely important. The consult is, in my world, the consult is a procedure. I look at it as a procedure, no matter if you charge $295 or $595 or $1,000, or just don't charge zero, because if you don't charge for a consult, all it delivers, the message would be the consult is worth nothing, zero. So it's not a good idea to give away the consult for free because you'll attract the wrong type of patients. And I think we all know that. Probably preaching to the choir. That's where we establish a vision, the vision for the final restoration. It might not be possible to complete it during the consult, but that's where we'll take all the records that will allow us to create a vision with the doctor and with the technician. And that's where you get control over the case. If you just see the patient, get the tooth out, place the implant, do it quick, you might lose control over the case. And I'm going to share with you what happens when we lose control. We don't want that. Very briefly, clinical exam, comprehensive periodontal evaluation, probings, measurements, and using some of the technologies I'm going to share with you. Imaging. We don't start with a CT scan. If the patient doesn't have a current FMX, we take it. Sometimes I throw it in, it's that important. I can learn from an FMX so much more, often, so much more compared to a CT scan. And I know a lot of the surgical specialists are just focusing on the 3D, which is also critical to do. Optical scans, full arch with a bite. And the 7 photos, and I learned this from Rafi, and we teach this in our courses, there are 7 photos we need to take. And this is Rafi's referral slip, mostly for big implant cases. But photography is part of your practice. It's a procedure. The camera has to be used all the time on daily basis, on hourly basis, because we need to document it. We need to learn about our case through photography. Okay, this is critical. For big cases, although we are periodontists, we try to do our best to assess VDO, especially for big arch cases. And there are different products on the market. The product that we use is this one here, thanks to Dr. Roxanne, who introduced me to this one. And it allows you in a very simple way, and actually I didn't know it was that simple, to see if the patient lost vertical dimension of occlusion. We can go through a process of adding composite and trying to find out how much did they lose, because our technician will need that information, mostly for the full arch cases. Okay, we're not playing prosthodontists, but we have some tools to work together and establish VDO. So we got all the records. Now is the time for virtual planning. I divided into small and big cases. When there's a small case, which is for us 1 to 4 implants, we do all the planning in-house. We have Mr. Jose Franco, who is my assistant here for almost 20 years. He does the planning, and it's amazing to see that a very intelligent, very capable assistant can do the planning, and the doctors will come in and will fine-tune it. The responsibility is on the doctor, but the initial merging of data and initial planning of implants is done by Jose, and the doctors will finalize it. For bigger cases, we'll send all the records to Rafi, and that requires a separate session. That we cannot do on the fly. We got to book that appointment when we have time, and we sit together online and we review the case and we do all the planning together. So a simple case like that can be done easily in the office. 1 to 4 implants, whether it's delayed or immediate, we can plan it. We can either do a virtual wax-up or scan in a diagnostic wax-up or order a wax-up from Rafi and find out what's the ideal position for the implants, and then from here, finalize the case, print the surgical guide, and execute in part 2. When it comes to bigger cases and loss of video and high complexity cases, we need to have a separate planning session where Rafi will introduce the setup, merge all the data, all the stuff that we don't want to spend 20 hours doing, which he can do probably in 15 minutes. He's going to merge all the data, and then in a session online, we will finalize the position of the implants, and print the guides. And if the technician is doing the planning, he or she will print the guide. Now, planning is one thing, communication is another thing. If we don't communicate, we're going to lose control over the case. So that's why you're getting a bunch of emails from me and the other doctors about the case. So usually in the form of an email, I also like to text. So I'm texting you so you can see that we plan the case. And usually in the email, you'll see the following. You'll see the planning implant in position X, the implant type, the positioning, meaning the trajectory, is it screw retained? We always aim for screw retained, cingulum access or occlusal access. And if it's not possible for different reasons, we'll communicate it ahead of time. And then we'll think through other options. And then we'll ask for some comments. I want to say 90%, you guys and ladies just check it off and say it looks pretty good and leave us alone. And that's okay. But there's a 10% where you say, you know what, I actually like those implants differently, or I think we should do something else, and that's why we communicate, okay? Then once we get the checkoff from the referring doctor, we'll send the patient a few things. It's going to be a bunch of documents. It's going to be the consent forms. There's going to be a cost estimate, a treatment plan. There's going to be an arbitration agreement. If you don't do it, maybe you want to have that. Pros and cons, I'm not going to get into that. And we send it through DocuSign. Everybody knows DocuSign. I know personally, I get at least every other day, I get a DocuSign that I need to sign, whether it's personally or professionally. And it's a brand name. I know we can get it probably for free. DocuSign is about $2,000 a year. I know it's a lot. But it's worth it because your patient getting a DocuSign to sign electronically, it's a brand name. It's a no-brainer. Versus sending the form, emailing, they have to print it, they have to sign it, they have to scan it, they have to send it back. It's a hassle. I don't like to do it myself. So DocuSign is a good thing, and there is also HelloSign, but DocuSign is more of a brand name. So they get the treatment plan, consent form, and cost. And the cost needs to be proportional or proportionate to the value that you're giving. So you can interpret it any way you want. So if you're providing high value, high level treatment, the cost needs to be proportionate, it needs to be high. No patient is looking for the cheapest dentist or cheapest surgeon. Sometimes the opposite. I'm not saying price yourself out of the market, but if you're providing high quality care, your fees need to be proportionate to that, meaning high. Okay? Enough said. I want everybody to be successful and be generously compensated by patients. Now, if you skip part one, which is probably 30% of the market skips part one, everything I just described in 5 minutes, this is what happens. You're going to lose control over the case. You're going to get malpositioned implants, impossible restorations, tissue collapsing. That affects emergence, that affects aesthetics, it affects function. Patients are unhappy, and you're losing control, plus you're losing your reputation. A lot of bad things. So as simple as a consult and merging and planning and communicating is going to save you a bunch. That was part one, pretty simple. Part two is execution. We get to work, that's day of surgery. It can be an hour, it can be 5 hours. It's the day of the procedure, we come prepared, and we don't want to be in a situation where we will have aesthetic nightmares. Because literally, you don't sleep when you have these types of situations. The focus in ridge building, of having a great ridge, or as best as possible under the circumstances, is to use something called the anti-collapse extraction technique. We call it the ACE technique, using sticky bone. I'm going to talk a little bit about the pedicle and custom healing abutments. So I'm picking and choosing certain things that are not being talked about that often. Because to build up a ridge like this is a nightmare. So my message here is, when a tooth is infected, get it extracted ASAP. Push your patients, and you're very good about sending the patients over for extractions. But patients with infection around teeth, it's just a time bomb. So the longer they wait, the infection continues, the bone gets lost. More infection, number one, it's unhealthy for the body, not to mention that, but it's also unhealthy for the ridge. So the extraction will be very easy, but the reconstruction will be also a challenge as well. And it's possible to do, but it's just a nightmare. So an infected tooth, a fractured tooth, belongs in the garbage, and we need to move on to the next step. Larger defects obviously require ridge augmentation. We can't place implants in a ridge like that, just to make sure. When there's no buccal plate, it's just too risky. We don't want to take any risks. It's just not worth it. So we build it to ideal. We use a technique called sticky bone, where we take the dry bone with a process of platelet-rich fibrin and creating something called sticky bone. We can take that bone and mold the ridge as best as possible. It has, like Play-Doh, you can mold it and you can cover it with a membrane to contain it and close it up. And it has a way better chance to heal when it comes to those big defects. And this is just an example. And I'm not saying this is a typical case, but it's pretty common. These types of ridges, these defects can be regenerated. It's possible. If we lose the width, it can be augmented. If we lose the height, it's way more difficult. So we are finding ourselves in other situations, like sometimes preferring a bridge over an implant in certain circumstances. The implant is not always the solution. It's not for every case. Okay? There's Maryland bridges, there's other types of bridges. But it's great to have a tooth with resorption extracted and keep that thing. Now, you heard about ridge preservation. We've used this term for, I think, almost 30 years. The ridge always collapses. There's not one human being that has a tooth extracted, fully extracted, and the ridge stays the way it is. It just doesn't happen, because the body ain't stupid. When the tooth is there, there is a PDL, there's vascularity, and there's function. When the tooth is gone, we need to save energy. The bone starts to shrink, the gum starts to shrink, we're going to get some issues. So the principle, wherever possible, we want to keep a small segment of the tooth. This is a case I'm working on with Dr. Cosgrove, with Gaby, a tooth with resorption. Interestingly, we're not going to mention the patient's name, but it has the word gray in his name, and he has a gray tooth. It's I don't know. It was meant to be. So Gaby, you were right. So there was a bunch of resorption, inside the tooth. The tooth was obviously hopeless. So what we're going to try and do, using the anti-collapse extraction technique, we're going to try and keep the buccal segment, the segment facing the buccal, which is the most important from an aesthetic point of view, and remove the palatal aspect. And I've shown this many times before. And this is called the ACE technique, conventional bone grafting. Sometimes we place an immediate implant, sometimes it's a delayed implant. This was more delayed. And that's the way to preserve the ridge, I want to say close to 100%. You just need to know that technique. Because technically from let's call it the body's perspective, from the ridge perspective, the tooth is still there. Even if it's just a fragment on the buccal, and you can see the stippling and you can see the contour, because from this perspective, the tooth is there. There's living PDL. And there are some indications, some contraindications for that. And that's what we are seeing here. And then if we can add a custom healing abutment, it's way easier when it comes to a restoration. So if you get a patient presented to you with a custom healing abutment, it'll be a much easier restorative process. And it's maybe not the ideal contours, you can probably improve on that, but it's a good start. And I'm going to share how we make the custom healing abutments. It's pretty simple. Soft tissue, not to mention as a periodontist, it's probably the biggest focus. And this is a case I worked on with Dr. Andy. This could be a potential nightmare. And if we don't get a good result from a soft tissue perspective, I'm kind of off the hook in a way, because ultimately the patient is going to get stuck with the dentist, and you can use pink porcelain, but it never looks good. It never looks good as the tissue. So the strategy we had here, and we decided to go with an implant restoration. This tooth is obviously hopeless, fully resorbed. The strategy here was to use two techniques. One was the ACE technique, anti-collapse extraction. I actually asked Andy to cut the tooth subgingivally so we get additional tissue. So that's free. The body just covers it, so we get some extra tissue. Here's the buccal fragment left on the buccal, obviously. And to add some tissue, we used a technique called the pedicle graft. What's a pedicle? A pedicle is a type of graft that never gets disconnected from the body's blood supply. And it's harvested. You can see it here. I'm outlining it for you, keep it simple. It's harvested from the palate, but we never disconnect it. It never comes out on the tray. It stays attached at the base. And what's the idea? It always has blood supply. What does it mean? It's going to work in a very high predictability, very high success rate. Okay, so this is not a new technique. This has been around for a while. And we flip it over to the buccal under the tissue and graft it, hope for the best. Temporary bridge goes on top, wait a few months, and the rest is restorative, because the dentist, Andy, can mold the pontic and get a really nice result. So a lot of it here is surgical and restorative, both. And we try to maximize the tissue and maximize the bone, and this is one happy patient, so very well done. Lastly, in part 2, customization. Every patient is different. And for years, I've used conventional abutments, especially in the aesthetic zone. I don't think about it much, because as long as the implant integrated, I got enough bone and tissue, patient's back, the email goes back, it's ready to go. However, what I didn't think about is, what does it take for the restorative dentist to start building that contour? And how convenient is it if we can start building the contour either during surgery or during the healing period? And it's actually not that difficult with a custom healing abutment. So check out the difference, the emergence for a custom healing abutment. The patient is already anesthetized, so it doesn't bother them if you push on the tissue. Dr. Lloyd and Dr. Alex were restorative dentists for a few decades. This is a pretty simple thing to do, and I'm going to share the technique. And I think using custom healing abutments should be a standard when it comes to implants in the aesthetic zone. It just facilitates things where possible. And I think we all understand why. How do we make them? We have lab fabricated and in-house. And both are pretty good options. What does it mean, lab fabricated? It means that we take an impression, or we send the lab the surgical guide with the guided plan, and they make it for us ahead of time. Because if you get a case like this, and Gaby, I think this is still, again, it's your case. It's kind of hard. You have to anesthetize the patient. You got to hurt them. Let me be the bad guy. We'll do all of that. So this is a lab fabricated custom healing abutment. It's never right. It's never 100%, and that's okay. We still need to modify it, and it's pretty simple to do. So that implant that is about 3.54 millimeters sub G is connected, or the abutment is rather connected to the implant, and we start modifying what we have. We mark the tissue where it is ideally, and we trim the rest. And it's not that difficult to deliver that custom healing abutment. And this is lab fabricated. We don't have to worry about it too much. And that's obviously a way better system than restoring with a stock abutment. In-house, and again, Jose is leading this in our practice because he's the tech guy. We use a system called Cervical, and it allows us to make custom healing abutments in-house. It's very simple. You save a little bit on the cost, I think, compared to the lab, although that's, I think, negligible. But we have more flexibility. We can make the healing abutment, custom healing abutment in-house. We, first of all, pick the abutment. It's a beautiful system, by the way, and it's very affordable. We pick the contour of the abutment that we want, more or less. I mean, we know the anatomy of teeth, or mostly the cross-section around the CEJ. We pick the right abutment. We have a tie base, screw, and the adjustment process is pretty much the same. Sometimes it takes me longer to do this compared to the surgery, and I charge some low fee for that, probably too low, but I think it's important. And then we modify it, and we attach it. This is Jose's expertise in the office. I do the adjustment, but everything in the lab, Jose does for us, and we can deliver it. And that's a way better way to go in terms of the soft tissue healing. And we started to do some custom healing abutments for molars as well. I don't think it's 100% necessary, but you know what, why not? It's just as simple to make, using the cervical system, to use the same system, and this is after some time when the patient is healing, these abutments get stained, but you can see the contour that gets created as compared to how it would have been with a stock healing abutment. We talked about part one. That's super important, consult and communication, simulation. We talked about execution. And not less important is, was our treatment successful? Can we verify that the implants integrated so we can check them off and let you know that you can restore them, no problem? So how do we verify implants? In the past, it was the knock-knock method and an X-ray. Just knock on it, sounds pretty good, and good luck to you. And not in a nasty way like that, but it was not very scientific. So we use the Ostel, and it gives us, for many years now, it gives us something called ISQ, the implant stability quotient. What is the Ostel? It sends a magnetic energy to the implant. That peg is connected to the implant, and it's going to vibrate, and it's going to give us a numerical value between 0 and 100. The higher, the better, through something called resonance frequency analysis, RFA. And that's one of the products on the market that's been there for a long time. So it measures how the implant responds to the vibration, 0 to 100. Okay, 0 is pretty much, it's floating. 100 I've not seen, but I've seen implants in the 90s. And it doesn't mean higher the better. Anything over 70 is considered high stability. So the peg is connected to the implant. The Ostel machine doesn't have to touch it, just has to get close, and you get green, orange, red. And green is anything over 70, orange is, we'll see in a second here, 60 to 70, moderate stability, and below 60 is low stability. Doesn't mean that the low ISQ are bad. So don't freak out if you're seeing a report that says the ISQ was 59. It doesn't mean the implant is garbage. It means we need to let it heal longer. I love over 70, but it's not my responsibility. My responsibility is to do precision surgery. That's my responsibility in Planet, and do a good job. Patient's responsibility is to heal. And so we want to know this number, and we check again 2 months later, and there's a chart that gives you exact indications. I don't follow that at all, because a lot of it is clinical judgment. Okay? So that's a magnetic test. The testing is done at the time of the placement and 2 months later at the check. I want to talk to you about something new, which is mechanical testing of implants. And I'm not talking about tapping on the implants. I still tap on them because I like the sound. But I'm kind of used to it. But mechanical testing using the inner view. So at the moment, I know there's only 2 doctors in this room that have it. What is inner view? Inner view is quantitative percussive diagnostic or percussion diagnostics. It's a great technology that was invented by Sherilyn Sheets. Most of us know who that is. What does it do? And I'll explain how we use it in the office. It measures the dampening characteristics of the periodontium. Dampening means the energy exerted or created from an element that is moving. And it's a mechanical test for teeth and implants, and it gives you something we never had before. In the past, especially as periodontists, we use mobility classification, 1, 2, 3. It's not very accurate, it's very subjective. We know what's a class 3 mobility, but it's very subjective. Here we're getting an actual numerical value for mobility. So how does it work? There's a very gentle vibration that gets created with this technology, like a mini hammer, like a tiny hammer that taps on the tooth 4 times. It has a base station. It's obviously wireless, and it has a tip. Now the tip has to be changed, every patient, obviously. Yes, don't be cheap. Okay, we change the tip because the tip has a chip. And by the way, the chip, they're the smartest company. The chip is going to work for 1 hour only, anyhow. The smart company. So that chip needs to be charged, and it checks 2 things. And I'll do my best to explain it. And there's a lot of technicalities here, and we can have separate lectures on that as well. It checks the mobility. How loose is the element? How loose is the tooth or the implant? And it checks another component. It's the internal mobility, something they call NFE, normal fit error, and I'll explain what it is. It's how abnormal does it respond mechanically, implant or tooth, and I'll show you some examples. So here's the machine. You see those taps on the tooth. And I had a conversation this past weekend. I spoke to Sherilyn Sheets. The amount of pressure on each tap is 29 newtons. It's a measurement of force. To break a restoration is 200. Now, it's 29 times 4, because it's 4 taps. In any event, in a scientific way, a mechanical way, it's not going to break a veneer, but dentistry is not just about science, it's also about psychology. Okay, so this is the information we're getting. We're getting mobility, 0 to 100. We have a range. There's a beautiful thing, and I'm a geek about these things. Every tooth gets a wave, and I'm still working through interpreting the wave. there's a range. And in the system, around 50 to 70 is a normal range. And implants have also a different range. The NFE, the way I understand it, a normal tooth, a healthy tooth, should respond in a certain way. There's going to be a certain, let's call it the bell curve, which is the average. The NFE is how far does the particular tooth or implant deviate from the normal. That's why they call it the normal fit error. Let's just call it NFE. And what it really means is what type of internal mobility is in the element. Is there a loose restoration? Is there a crack that in the microscopic resolution is vibrating? And is there an implant that has a loose component inside? It could be a loose screw, it could be a broken screw, it could be a broken implant, it could be a loose restoration. And I love the NFE because when we check mobility, I kind of can guess which teeth will be high on the mobility chart, but with the NFE we get surprises. And I believe that now that when we see NFE that are going high up, it's our responsibility to communicate this to you and to in particular check these teeth. For example, this is a case with Dr. Schwartzman. A patient had some sort of discomfort on the upper left. Okay, this is Angela. And nothing showed up on the radiograph, but the NFE was pretty high on the upper left. Teeth number 14 and 15. Mobility was within the range, so the NFE was pretty high, and that tells us that something mechanically is misbehaving. It's not 100%. And I believe that it's in the process of replacing the restoration, as the restorations need to be changed. And maybe you can make that decision based on clinical judgment alone. Probably can. If you're experienced, you probably don't need that, but the patient saw that, and I think they called Dr. Schwartzman right away to get this addressed. So it's a great technology, great things that we're seeing now. So what can increase NFE? What can increase internal mobility of a tooth? Cracks, root fractures, bone loss, changes in periodontal support, bone loss because of a fracture or other reasons. And for implants, bone changes, loss of integration, internal instability. What is internal instability? It could be a loose screw. I mean, the restoration doesn't have to be wiggling, but sometimes there's a small screw, and what's the problem with that? What's the big deal? It's a big deal because next, the screw breaks, or it's stripped, or it's deformed, even worse. I prefer if they break. And then it's a nightmare to remove. And very often, those changes are seen before they're actually symptoms or things that you can see. So this is one of the implants I placed. I never felt good about this implant on different levels. And although it was not mobile and looked pretty decent on a radiograph, look at the mobility. Very atypically high. So this implant is already bye-bye. It's gone, and we are regrafting and doing it again. So just things to remember about interview. Checks mobility, how much the element is moving, how much is a tooth moving or an implant, and is there any internal mobility? How stable is the structure? And then interestingly, and that's Sherilyn shared with me on the weekend, the software is SaaS, meaning it's pure online. You don't install it on the computer, you have to log in online. So they're collecting a lot of data. And currently there are about 200 practices in the world using interview. And they checked close to 6,000 patients. And this is a crazy number. 75% of these patients have at least one tooth with an NFE greater than 66. So they have the stats already. What does it mean? It means that we're missing out on a lot of cracks, asymptomatic cracks, and we have another way to measure. Now, we spent about an hour on a surgical procedure, 2 hours or 5 hours. Often, at least in the past, we don't spend enough on healing and optimizing healing. most dentists, most surgeons that place the implant, they pretty much stop. They just wait. Let's just wait 2-3 months. Nature will take its course and we'll have a healed implant. We now know it's not true. There are ways to optimize healing, and we're not going to talk about all the ways, but obviously nutrition and following the instructions and taking the proper medications and sleep and stress reduction. That's a whole lecture by itself. And the way we look at it, when we talk about healing, there's the traditional thinking and there's the modern thinking. Traditional means place the implant, wait, and check integration. But the modern thinking is place the implant, optimize the healing, monitor the healing, and then check. You'll have a greater chance of success. I think that's the obvious. How didn't they think about it before? So how can we optimize bone? Because bone is obviously what implants need. They need stable bone and the process called osseointegration. We need to understand bone. We need to understand how bone works. And we need to know that bone is a dynamic structure. It's not rock, it's not cement. It's a living structure that is influenced by a lot of things like gravity or lack of gravity, influenced by pressure, vitamins, even cholesterol, hormones, trauma, and also vibration. And I want to talk to you a little bit about the element of vibration because it's very poorly explored in our field. It's been a principle that NASA implemented in the 60s. This has been around for 60 years. Vibration influences bone in a positive way. So astronauts that are in space with no gravity, they're going to start developing early osteoporosis. I mean, and these astronauts are beasts. I mean, these are superhumans, but they're going to develop osteoporosis because of the lack of gravity. Hence, vibration plates were invented. And it's not a thing of the past. After I learned about vibration plates, I found one at home. I never knew we had one. And the idea is that when you vibrate bone in a certain frequency, you're going to improve healing. You're going to improve bone vascularity and healing and other benefits. And then I went into the rabbit hole of doing the research, and I'm not going to bore you with all the gazillion studies that are out there about vibration and bone, and specifically vibration and alveolar bone, which is the bone that we are fighting for every day, the bone that supports the teeth. That bone goes bye-bye when we extract teeth. So if there's a way to strengthen that bone, get better healing, vibration is a very good option to utilize. So what does high-frequency vibration do to bone? I'm just going to summarize it for you. It stimulates bone-forming cells, the osteoblasts, creating new bone. This is called osteogenesis. It reduces the osteoclastic activity, which are the cells that absorb bone, and it increases growth factors. So when I saw this was like music to my ears. To know that there's something pretty simple that we can use, and the vibration plate for the mouth is called Alveo 5. So I'm going to share with you, I have one here if you want to see. It's brand new, so no worries. It was in nobody's mouth. The Alveo 5 is a one-size-fits-all that the patient can use to create high-frequency vibration in the jaw. It does 5 things, and this is why it's called Alveo 5. It does the 5 things as follows. It creates and optimizes bone. That's the osteoblastic activity, reducing osteoclasts and fibroblasts, etc. It accelerates bone creation in bone grafts. It accelerates osseointegration, so there's some studies coming out on faster osseointegration, improves periodontal healing, recovery after periodontal surgery and general health, and some pain relief. There are other benefits that I'm discovering as I'm using it that are not claimed by this company. But the things that were scientifically proven are the biologic benefits, which I mentioned to you before. What I really love about healing is that we know more about how healing works, at least in today's world, using PRF, PDGF, other growth factors, GEM21, which is PDGF. using peptides, using different elements that can enhance healing is very well established. What we are lacking is how can we not buy products for thousands of dollars or charge the patient thousands of dollars for healing using something they already have in their body, built in, that we might be able to upregulate with vibration. So with high frequency vibration, we have two types of patients that we use in our practice where we use this technology. Surgical patients, patients that are about to have a procedure, and patients that are just interested in jaw wellness, that want to have better oral and masticatory system. So in surgery, the protocol is the following. A week before, the use is 5 times a day, 5 minutes each. If I had extra 25 minutes a day, I don't know what I would do. I don't know, an extraction maybe. But it's important for the healing. And after 1 week after the surgery, they keep the same protocol for about a week, and then continue at least twice a day for maintenance, because compliance is an issue with patients in general. I have one at home and I use it. Sometimes I forget, it's a drag, but if you get into using it, it becomes a habit, like anything. For jaw wellness, they don't have to use it 5 times a day, twice a day, and we use it for periodontal patients, patients with TMJ. Xerostomia is something that I found accidentally, because a lot of our patients losing teeth or losing a full mouth of teeth, they have rampant decay. And because of xerostomia, patients told me, you know what, it's squeezing more saliva out of my glands. Now, if they have an organic issue with their saliva, that is not producing anything, then it's not going to help. But if it needs some stimulation, it definitely helps with xerostomia. So here are my first cases. Gingival recession, and I've been using this for about a year now, close to a year. This patient needed a graft. I harvested the graft. I had a surgical error, and I created a graft perforation, which the periodontists in the room know exactly what it means. When you perforate your graft, you're hurting the vascularity. The thing might slough completely or partially. And things happen, even with care. Here's the graft sutured, and there's not a small perforation through and through. This patient was using vibration, healed beautifully. Within 2 weeks, couldn't be better. Is it the vibration? I don't know, but I threw anything I could at this case, and it definitely helped. Second case came in, patient came in crying. She's in ortho. I'm going to lose my teeth. And she will lose her teeth. Mobile teeth are not good candidates for ortho. Literally class 3. I didn't have the interview at the time. We're starting to see widening of the PDL. We're starting to see depressible mobility, which means we're starting to see almost like periapical lesions, although the teeth are vital. I recommended a graft. This time I didn't perforate. It was good. Great healing. We added high-frequency vibration to strengthen the bone. We added splinting. We use vibration as an adjunct to healing, to optimize healing. It's not one thing. What is the healing attributed to? Is it the patient's habit? Is it the instruction? Is it the antibiotics, the vitamins, their health, the sleep, vibration? We want to put in all the things that we think are going to help with the healing. And what's nice about this case, she's not going to lose her teeth. At least not on our shift, because the bone went back to normal and the teeth stabilized. She still wants to take the splint off and do veneers, but I vetoed it because I don't want her to lose her teeth. Third case was an early failure, also Aaron's your patient. Early failure, 4 weeks later, implant just came out. Bad healing. Use vibration only. That was the only difference. And got another implant in there with close to 90 ISQ. Okay? It stimulates the bone to heal faster, get a faster osseointegration, at least in the cases that I've seen. And I'm going to share a couple of cases from other doctors. There are a couple of doctors in the United States that are using vibration. We share our cases because we want to learn what other benefits might be in the process. This is from Dr. Bobby Horowitz from New York. I think he's in NYU. He's starting to take cores from implant sites. He's starting to see how soon vital bone gets created in the sockets. Pretty fast. Full vital bone in 7 months. He's starting to treat patients with peri-implantitis, doing the grafting, using the vibration to expedite the healing. I mean, these are old people. It's close to 90 years old. You don't heal that well at 88. But he's able to show on multiple cases how the bone comes back. I guess he has a geriatric practice, but a lot of older people, which is a great way to test. On a young patient, you just look at them and they heal. They don't need to do anything, but all the patients, we know what happens there. So we're seeing a lot of promising results for a lot of the compromised patients. This is another case from Dr. Horowitz, where we're starting to see faster healing, more bone regeneration through the vibration process, and a couple of the publications that came out already show increased density around implants, where that was the only element, just through the vibration. So that's something we use in our office. Some patients report less pain, more anecdotal from my perspective, but some studies are starting to show that there's some TMJ pain that gets alleviated. Is it placebo? Is it distracting? Is it distracting from a different type of pain? But studies are coming in showing that this is very helpful. So I personally love the fact that it upregulates growth factors. Forget about a beautiful smile. Forget about aesthetics. It's the health of the body. If it can increase growth factors, you will get better healing. And I wanted to share this technology with you.
I feel so privileged to get to work with the whole crew here, and Ziv has been a brother to me, and we do have a great time in our car rides together, and I'm always telling him the latest stuff. And so zirconia implants is probably something that people have been skeptical on. I understand why, because it has a learning curve. There's a little bit of woo-woo in here, and a lot of my patients are a little woo-woo. A lot of crystals, a lot of burning sage, and sandalwood. And hopefully I give you some useful information tonight so that you can understand zirconia implants better. I think the demand is going up. Patients are becoming a little more aware of not wanting metals in their mouth and being healthy, and so definitely there's some challenges because zirconia implant so far has not been made where you can screw retain it. They're all cementable, so that adds an extra element. So we're always working on that. So what, first of all, is a zirconia ceramic implant? It's made from zirconia, not zirconium, which is a metal. And it's a material that's really used in a lot of industries, the aerospace industry. So it's a very strong material. And it's metal-free, no potential for corrosion. It's biocompatible. The tissue heals well around it. Definitely has its aesthetic element. Sometimes you see a little dark area around a titanium implant, especially in the aesthetic area, and with the zirconia you won't get that experience. Also, with the holistic patient, this is what they want. So the two systems that we use in the office are the SDS, and so there's two types of SDS implants. There's a one-piece, which basically the top part is the abutment and it's attached to the implant. And this is the two-piece where this part gets cemented into the actual implant. The advantage of the SDS implant is that I use it a lot for immediate implants because it has a great cutting ability and you can get it in with good stability. And then there's the Ceraroot, and I especially like this type of system in a healed site, and also when I'm dealing with in a posterior area, it has a little more width to it, so you get a better surface area. All these implants are all preppable, so you do want to leave them a little bit above the tissue so you can have a little ferrule effect around that part of the implant. So who's a good candidate for a zirconia implant? Same thing as titanium, you have to have adequate bone, good oral hygiene, you still need to take care of your mouth. Non-smoker, smoking definitely affects everything. And patients that are looking to avoid metal, and actual patients that do have metal sensitivities. And also, stuff that where a patient has a thin biotype and you're looking in the aesthetic area, they have thin tissue. So this is an example of just the healing. This is courtesy of Rashad. Thank you, Rashad. Wait a few of your slides. And you can see how nicely it heals around there. And as you can see, the collar, this is a two-piece, and you can see as the collar comes out of the tissue, and so that's preppable. And you'll see shortly an abutment's placed in there. You know what? I realize it's been a long night, so just take a deep breath and just actually, I don't know if people heard about humming, how when you're stressed out, a great way to actually relax your whole nervous system is to hum. And actually the funniest thing was when I was younger, growing up, I had an older brother, about 9 years older, and we'd be hanging out, and on Sunday mornings he'd be reading a newspaper and he'd be humming. And I didn't really understand it, now I do. So this is the SDS two-piece. This is looking down into the implant where you put in the abutment. That's the cover screw that's put in after the surgery. And so this is the actual abutment that's screwed into the two-piece. That screw's taken off, and then it's cemented in there. And so you can see that this is the part of the implant that would be up here. And this is the collar that you see over here, and there's the abutment. So this is the cementation of it. And this is a root, and you can see how nicely it's formed around the coal area and the papilla. So that's the lab case, and look how nice it goes in there. So questions that patients will actually ask, will it break? It's made of the type of ceramic of a mug. And so really, zirconia is very tough material. It's jet engines, and it'll definitely hold up over time. Not to say that you can abuse it. You can break anything. You could break a titanium implant, the screws and all those components. So is it as good as titanium? In the osseointegration's comparable. And so for the right person, it delivers a good result. Patient says, my friend had titanium for 15 years, why change? So, titanium does work well. Ceramics do as well. They have their, each have their benefits and limitations, but definitely for patients that are looking for biocompatibility, not having metal in their mouth, it's definitely their choice. And is it covered by my insurance? So ceramic implants are, there's nothing usually excluding them. You have to check with their plan, and it's just a matter of having that conversation. What do you say to a patient about these ceramic implants? So, have a 10-second answer. It's metal-free, it's white, and it's a holistic option. These patients that are actually looking for this, they are usually people that do a lot of research, and they're usually very adamant about, oh, I want this, and they really know what they want. So this is just an example of a case doing the immediate atraumatic extraction, putting our bone graft around there, and how nicely it looks on the x-ray. And so with the tissue healing, we'll see pink, firm tissue. You know, there's no swelling, no redness. The surface of the ceramic is smooth, and so it helps to resist plaque accumulation. And also, no gray shadow that you see. And I wanted to thank you all, and have a great rest of the night, and I'll pass off the mic to Dr. Alex.
So today I'm going to talk about sinus lifts, and this is a sinus lift. This is a pretty large sinus lift, and it's an open sinus lift, and it's invasive. You know, in a lot of instances, we don't need to do a lift of this magnitude. There are cases where obviously we're going to go laterally, and we're going to have to do a large lift if we're placing many implants or we have some deficiencies. But there's a way that I want to discuss that I brought into the practice that I use regularly that actually makes a more conservative lift for patients as well. And so I use the Versa technology, and I'm sure a lot of you have heard of it. I don't know how many of you guys actually are using that technology in your own hands. I've spoken to a couple dentists say they've gotten it and haven't learned on it yet, and it's sort of sitting in a closet not being used. So I do want to go over it briefly and discuss my experience with it. I'm not sure if a lot of you know my background, but I was a general dentist practicing for 8 years. I actually owned 2 practices before going to perio, and as a general dentist I learned how to use this, but I wasn't as confident and as trained in it as I am now. And so I do want to go over some things that I thought I knew and I didn't really know when I was a general dentist using this technology. So the clinical applications, really it's osseodensification, and that's what the Versa burrs do. And I use them in my implant protocol not just for sinus augmentation, but for these main clinical applications, improving implant primary stability. And Dr. Simon touched on that, using the Ostel to measure, the stability of the implant when you place it, and then 2 months later as well. But that primary stability is sort of the gold standard when placing an implant and knowing how things are. When we have good integration of the implant, when we have good primary stability. And we also can get some ridge expansion for implant placement. Rather than having to do a large augmentation or doing ridge augmentation, there's certain instances where we can actually expand or augment the ridge while we're placing the implant with these drills as well. And then my favorite use that I use in conjunction with the ridge expansion is the crestal sinus augmentation. We really want to understand why osseodensification was developed. And as I mentioned, the implant success is really influenced by primary stability. And we know Carl Misch with the D1 through D4 bone. I'm sure everybody had this hammered into them in dental school, but we have great success when we have primary stability in that D1 bone, that D2 bone, but when we're working in posterior maxilla or a site that we've extracted and grafted, we're really dealing with that D4 bone where we have a lot of trabecular bone, and we're not going to get that primary stability of that implant. And so that's one of the biggest challenges when we have poor bone quality. And traditionally, we've had to rely mostly on the implant design, and there's been a lot of discussion prior to these drills being made. All of the changes in implant dentistry were changing the implant, whether that was surface characteristics or increasing the thread pitch, or adjusting how that implant itself surfaced, whether it's additive or subtractive. And then they changed the mindset of maybe we need to change how the osteotomy is prepared, and that's going to change how the implant integrates. And so in the past, most of our implant drilling is subtractive. We're actually going to be removing a lot of that bone and then placing the implant into a poor site. And so what these drills do is, instead of removing the bone, reducing the surrounding bone density, and relying on the existing quality in that trabecular bone where there's a ton of marrow space, with the osseodensification is that we're actually going to use and compact that bone. So we're actually going to be running the drills in reverse, and instead of cutting away that bone, we're actually going to be condensing it and thickening that and making that kind of marrow space compacted. So we're going to get a stronger stability of that implant. And so in simple terms, we're converting the drilling where we're removing the bone and relying on the bone that's there. We're going to actually preserve the bone and help improve the quality of the implant site before the implant is actually being placed. And so this is the kit. There's multiple kits if you go on their site. This first kit up top here it's the big kit. It has long drills, short drills, VT5 drills, VT8 drills, and every drill has a lot of numbers. It's very confusing. If you break it down into simple terms, you're going to see that it's actually quite straightforward. And so I actually have this drill. I have the Densa Burr Kit X. I take it with me everywhere. I use it in almost every implant placement I do, even if I'm not doing a crestal lift. I'm going to really be using this drill in my hands. I find that I have great success. And what this is, it has the regular length rather than the short drills. And it has a combination where you can actually use this with most implant systems. And if you go on their site, they actually will have a protocol for probably every implant system that you're going to be using. So if you're a Straumann placer or a Nobel placer, and you're like, what's the sequencing of the drill sets that I need to use to place a 4.3 by 11, you're going to be able to find that online. Each drill is going to have 4 numbers. And so there is a designation. So you pull out a drill that says VT 2838. 28 is the diameter of the drill at the apical end. And then 38 is the drill diameter at the coronal end. So every drill is tapered. And so I always get asked, well, can you place a parallel implant if this is a tapered system? Well, there's a VT5, which is for tapered implants, but there's also VT8 drills. And so you're going to add those VT8 drills into your sequence to actually widen that osteotomy to place a parallel. So the moral of the story is you can place parallel, you can place tapered with the system once you get the hang of it. And the VT5 and VT8 are both in this little compact little one that I like to carry around with myself as well. This is for the ridge augmentation. There are many ways that you can actually, get adequate ridge width. We can do traditional grafting, we can do guided bone regeneration, but you can actually do ridge augmentation with these drills because we're osteodensifying, so we're actually expanding that, but there are some rules when it comes to that. So we need to have an ideal ridge. So we're going to want to have minimal initial width of over 4 millimeters. You're going to want to have more than 2 millimeters of trabecular bone, and you want that ridge to be triangular in order to allow for expansion. So you don't want to have a really narrow ridge at the base and a wide ridge at the top, or just a narrow knife edge ridge isn't going to work for that. And so here's a poor candidate. You're going to see a knife edge ridge. We're not going to be able to expand that as less than 3 millimeters ideal width. So resort ridge with a narrow base is not a candidate for that. We're going to look alternatively to like a guided bone regeneration. So application 2, this is where the money is. And I always use application 1 when I'm doing application 2. A lot of times when I'm placing implants in the posterior in D4 bone, I'm going to be using the ridge expansion or the osseodensification anyways. I want to get good primary stability of my implants. But the big thing is crestal sinus elevation. And my favorite procedures are sinus lifts. My favorite procedures are lateral sinus lifts. I do quite a few of them, but I don't do them if they're not necessary. I'm going to always want to go conservatively for the patient, and I'm going to want to do a minimally invasive procedure when I can. So the best application is for crestal sinus elevation. And so what we want to, if we see a clinical challenge of reduced residual bone height, poor bone density, and need for implant stability, that's posterior maxilla. Somebody has number 3, number 2, that you're going to probably be grabbing the Densa Burr for this, okay? So can we elevate the sinus through the osteotomy with osseodensification? And the answer is yes. And there's 2 protocols, and yes, we can. I don't want to go into too much detail because I know that you guys have been here for a while, but there's 2 protocols. The first protocol is if you have over 7 millimeters of bone. You actually don't need to even add any bone into that osteotomy or into that sinus. You're going to be able to osteodensify and raise that floor of the sinus and that cortical floor to cover the apex of that implant. Protocol number 2 is the 4 to 6 millimeter. I actually don't agree with that as much. I prefer a 5 to 7 millimeter. Under 5 millimeters, I find that there is a little bit larger risk of perforation, and I'm not getting as good of a result, just generally. But that's when we're going to actually add graft material. So I'm able to raise the floor of that and then actually add bone to propel the floor of that sinus, the Schneiderian membrane, up so I can place a longer implant. In the posterior maxilla, I'm trying to place a 10 millimeter implant, and in this situation, I typically can. And so some of the rules of the drill, you don't want to get that drill more than 3 millimeters past the floor of the sinus. So you're gonna let the allograft actually do the work. So I'm gonna drill to just a hair short of 3 millimeters past. So if I measure my CT scan at 6 millimeters, my drill is not going more than 9 millimeters through that floor. I'm gonna allow the allograft to do the rest, okay? And then you can place the implant simultaneously in both of these instances. Protocol 1, it's pretty straightforward complexity-wise. The first few times you do it, when you break through that cortical floor, it's gonna be scary, let me just tell you. You get used to it. It does fall, you wanna have a fulcrum, you wanna have stability. You'll be scared, you're gonna look into the sinus and you're gonna see you didn't perforate the membrane, okay? But it is pretty terrifying. And then protocol 2, there is a little bit more involved. Once you get through that membrane and you see the drop, you can do either PRF through the osteotomy and then whatever your choice of graft material is, whether it's allo or xeno. I prefer allograft. And then you're going to be driving that the graft into the sinus with a slow speed, 150 to 200 RPM. When you're doing osteodensification with these drills, I didn't have the text up because we had an issue with the font. But the way that these drills work is they run in reverse, so you are not cutting, okay? So you can cut with these burrs. You can run them forward, they will cut. If you run them in reverse, they're gonna densify. I do all of this in reverse, every step, okay? And so my clinical guidelines for doing the sinus lifts internally, over 7 millimeters of residual bone. I'm just breaking through that floor essentially, and I am actually osteodensifying in reverse, and I'm pushing bone up into the sinus. You can put an implant in there. You could put a 10 millimeter implant in. You're gonna have apical bone around the implant. Orange zone, the 5 to 7 millimeters. I don't really love the 4 to 6, so I changed it 5 to 7. Then I'm gonna go to protocol 2. I'm gonna break through the floor and I'm gonna start adding allograft and I'm gonna propel that into the sinus as well. And you can get up to like 5 millimeters of lift. You're not gonna go 5 millimeters with your burr, but you can get a significant lift. And then red zone, less than 5, I'm going lateral. And that's another whole other lecture that I don't want to bore you on, but you can do a lateral window and place an implant at the same time, but there's rules for that as well. So the steps are, first step, CT assessment. Okay, so we're going to assess how much bone do we have. You have the green zone and you have the orange zone, you have the red zone. Okay, if I have 7 millimeters, I'm going protocol 1. If I have 5 to 7, I'm going protocol 2. If I have less than 5, I'm going lateral. And then we're going to prepare the osteotomy, and then we go up to the 3.0 drill. That's the 3.0. It's a 2.5 to 3.5, meaning it's a 3.0 in the center, and you're at 3.5 at the coronal aspect. I'm going to go less than a millimeter, just a millimeter short of the floor, and I'm running it in reverse at 1,000 RPM. And then I'm going to take an X-ray with that, okay? Just make sure you're at the floor. Take an X-ray. And then in reverse, 800 to 1,500 RPM with copious irrigation, I'm gonna be pumping the handpiece and the drill and engaging the floor, and you will feel it will be very difficult and hard. And then you're gonna progressively elevate, and then it will drop. And you will freak out, but don't freak out if you have a fulcrum. And then no further than 3 millimeters past the floor with the burr. If I need additional elevation, like on the CT, I have 5.57, I'm gonna elevate the membrane by putting a collar plug. I prefer PRF. I will put PRF membrane inside there, put allograft, and then I'm going to use my burr 150 to 200 RPM without water in reverse and propel allograft multiple times, not just one. I'm going to keep putting it in there, and you're going to get a lift like that. Okay, and then you're going to take an implant, verify your stability, and confirm with the radiograph. And so that's a result that you can get. There are instances where you're going to hit the floor, you're going to push, and you're going to push, and you're going to push, and it's not going to go through. And you're going to increase the RPM, and you're going to go, this elevation isn't working, the cortical floor is so strong, what do I do? In that instance, you're taking the pilot drill, and you're going to perforate multiple times on the floor, and you're just going to go for it again, and it will break through, and you'll be able to get a really good lift. So this is a great way. The patients love it. They don't have any post-op symptoms. A lot of times patients feel as though it's just like a regular implant, that they don't even realize that I've done a sinus lift. So you got to prep them in the beginning that, we are doing a sinus lift, show them the radiograph because they won't believe you and they'll go, what did you charge me for? So, but yeah, patients are loving it and we see great results, great stability for implants. So I think that's the end of my spiel. Thank you guys.
We're doing so many new things that are not having been educated when I went to dental schools. And the most important thing for me that Ziv will have to keep me screaming and kicking out of the office, that I want to be there because I am very fortunate, and I can only give everybody the advice. If you can get yourself a good associate, if you can have partners, and if you can be as fortunate I have been to have somebody like Ziv for over 25 years, and then have the addition of Lloyd and Dr. Alex, there is not a day anymore that I don't give any more pearls. I receive pearls every day, plus a laugh, a little bit of meditation by Lloyd. So it's really fun to practice. I want to review something that every periodontist is able to do, and every one of you knows the problem of periodontal patients having recession. This is our bread and butter stuff. Like you do simple restoration, we are used to treat recession, and we are confronted every day with patients who have extensive recession. And the main reason why you are concerned about it is that some patients don't care about it, but we know that eventually they cause sensitivity, caries, and the most important thing is they contribute to bone loss, and an extensive recession makes the tooth also less stable. So our bread and butter stuff was to treat those areas with gingival grafts, and we know they worked very well in the beginning, just simple with free gingival grafts, but we perfected the technique of taking tissue from the roof of the mouth, the palate, and since we have perfected the technique of doing donor tissue, palatal tissue, we still, and you have the trouble to convince the patient to have this procedure because everybody dreads the pizza burn, the roof of the mouth. But now with the technique of doing gentler surgery and having PRF, they survive it, but people are dreading it. The problem becomes when a patient like this presents to you with an area on the upper right, upper front, upper right, upper left, lower front, and now you're thinking like, how am I going to get this patient back maybe 2-3 years later if we are starting to do gingival grafts on the upper right, upper left, the lower right, and we are waiting for the palatal donor sites to heal, and it takes 6 months, and then we have to go back. And this presents a challenge, and I used to joke that this is like the 5-year Russian plan until the patient gets back to you. And unfortunately, a lot of patients quit after the second surgery because it is painful, it's time-consuming. So what is the answer for something like this where nearly a full arch needs to be treated? Basically, I was lucky to be exposed because it has, and unfortunately is not being taught very much in dental school, to be introduced by somebody who invented a new technique. It's the tunneling technique. What is tunneling? Tunneling basically means that we are creating a tissue tunnel, and we are creating a bed to receive tissue. And now, instead of only being able to take tissue from the roof of the mouth for 2 teeth or most 3 teeth, we can combine the technique of knowing that donor tissue behaves very similar to the connective tissue that we are removing from the palate. It totally falls apart, totally regenerates into dense connective tissue. And that's one thing that we are trying to educate the patient. Do I live with somebody else's tissue? What do I expect? There is 0 rejection rate. It's normal healing. It just takes a little bit longer. And the only challenge is to create this tunnel without separating the papilla, and that's the cardinal rule. As soon as we break 1 or 2 papillas, we're in trouble because then we have a very compromised healing. And then we are, after the tunnel is being created, we are squeezing this donor tissue in that takes a little learning curve, and I call it like the reverse birth, and basically soak the area, the donor tissue in PRF, and there is a very particular technique to suture, which takes during this procedure actually the longest time. And after this procedure, if you happen to see the patient, it's not a pretty look because we are bunching up the tissue and we are apically repositioning it, and the papillas look bunched up. And the only, I don't want to call it side effect, but the only thing is that those sutures need to stay much longer than was conventional grafting, because the only challenge with this technique is that instead of your own donor palatal tissue that literally falls apart and regenerates in 2-3 weeks, this donor tissue takes about 4 to 6 weeks to totally disappear. And there are scientific studies to show that they basically create your own dense connective tissue. And that's why after a certain amount of time, we can get with one procedure, one surgical procedure, you can see the upper right, the front area, upper left area, as well as the lower front area being treated, with the big advantage that we have only one surgical procedure, one post-op event with very little discomfort. Unfortunately, it's less discomfort, but more swelling and kind of bruising that's very easily being handled. And we can deliver this patient in much better health back to you to either be continuing with restorative treatment or get back to your recall. And especially with surgery patients, we are always confronted with discomfort, and they don't know that we are removing a challenging distal pocket on tooth number 17 or 18, but this is very rewarding because they can immediately see this effect. So you can see here that, again, if we would treat this with a conventional donor tissue, we would have to go to the palate, at least to the upper right and upper left area, because we can't handle more than 2-3 teeth. And you can see this, that after the grafting, it is so much easier to provide a nicer result for the restorative dentist, and much better harmony. It's easier to clean, and again, done in one procedure instead of multiple procedures. It's a very rewarding procedure, especially in the aesthetic zone. And the only challenging part is that when we look at the next cases, when we are confronted with certain defects in the teeth, you can see here that we can get some class 5 erosions that we can cover, and you will see when it gets more extensive, we can get some very, very nice results. And when we continue, you will see that in some areas, it looks like if there was never any recession present. So my case, when a patient like this is referred to us, but one of you guys, well, it doesn't bother me. You know, I'm not planning to be veneers, and maybe they don't even have a high smile line. But most of the time they're already educated, and if not, what I try to explain to the patients that it's not only about the aesthetic, it's not only about the sensitivity, but when we get a case like this back, we are preserving the periodontium and preventing further bone loss. And I try to explain to the patient that when you have this kind of recession, in the normal circumstances, the bone is like 2-3 millimeters underneath there. If this recession continues, those teeth eventually, besides being sensitive, besides being more caries prone and maybe being bothered by aesthetics, you will lose bone. So this is not only an aesthetic procedure, but really preserving the periodontium. So here we see a few other cases where the Class 5 restoration may have been necessary, but here we are covering the area and restoring the periodontium without any kind of restorative treatment. This is very challenging for a non-surgeon to understand, because if the recession in the area of tooth number 8 would have been treated conventionally without a tunneling procedure, we would have to raise a flap. And invariable, we would compromise this papilla and actually cause some black triangle. By doing the papilla preserving technique and doing a tunneling where the papilla is not being detached, we not only get very good blood supply, but we get this beautiful aesthetic result. And we can see even with the donor tissue that we get this stippling that is so typical of when tissue is being taken from the palate. So here are just a few examples like pre-restorative, where we preserved the periodontium, got some root coverage, and then the patient was not happy about color and shape or whatever, and had some restoration after the procedure, with the big advantage that we got the case back not 2 years later, but a few months later, back to your practice. Here's another challenging case that without the tunneling technique, the papilla would have been compromised, and we restored it back to health without any kind of other problems. Please try to refer us the easy cases. Lower teeth are so challenging. The root proximity, the buccal loss of the bone, the tissue is so thin, but having done this procedure for all of us and developing a certain technique, just imagine that we are going with the instrument here underneath there. We'll have to tunnel this without any perforation, because once you perforate, once you detach any papilla, it's time out, and we explain to the patient, it's either we abort the surgery or we go back to taking tissue from the roof of the mouth and doing the conventional. So those cases sometimes are very challenging, but they work. And here's another case to show you that when you get those cases treated back from us, sometimes when there is only very thin mucosa covering the tissue and we advance everything, you will see a very light shine of the mucosa still covering it, because we are not changing the outside. But you will see that even if this very thin tissue moves a little bit, underneath there is very dense connective tissue protecting for further recession. Here you see a very challenging case where treatment was done. In this case, we discussed this with the dentist, should be pre-operatively put some class 5 restoration or not. The patient said, I don't care, I just want to be healthier and not lose further tissue. So after the healing, you can see that we got some tremendous root coverage. And in this particular case, I referred the patient back to do a much smaller class 5 restoration. And the patient decided, I want to just have it smoothed off. I don't care about the aesthetic, but at least I have some firm tissue preventing any further recession and further bone loss. In another case where we know that treatment needs to be necessary, but we can't put tissue over old class 5 restoration. I don't want to go to the boring technique of how doing it or whatever, but we basically are taking a lot of time to prepare the roots. In this particular case, we were aware that the class 5 restoration were very shallow, so I removed them, treated the roots, and I think got a very reasonable result without having to go back and redoing some class veneers. Lastly but not least, that's one of the fun things why I still love practicing. Most of our cases are being treated and being referred to you, and we are lucky if we see a 1 or 2 year post-op. This is one of my first cases done 15 years ago. How would you treat this case in a conventional way of doing individual grafting from the roof of the mouth with donor tissue? It's a 2, 3, 4 year project. We basically convinced the patient. I didn't tell her that she was my second or third case, but she somehow trusted me. And we basically created a tunnel on the whole maxilla. So you can see here the tunnel being created. Now you can envision the amount of available tissue by having the donor tissue being available. We can use as much as we want. So we basically have enough tissue from the molar to the central, and from the central going back to the other side of the molar, and insert this tissue into the tunnel soaked in PRF and growth factors, and then you will see the case being sutured. So here you see, and this is sometimes challenging, and sometimes this takes some time, but it's kind of fun. So here you see the donor tissue being inserted, the suturing technique, and 5, 6, I like even 7 weeks if I convince the patient to keep those sutures, and basically only topical anesthetic, 10-15-minute appointment with a light polish. You can see how the result is once we remove the sutures. Now, the beautiful thing about this particular case is that the patient was very motivated to get restorative treatment and some minor orthodontics. And basically, this patient was abroad and came back to us a couple of months ago. And this is a 15-year result, which really makes fun when you have a patient walking in 15 years later and actually smiling and thanking you for a surgical procedure. It makes all our hard work worth it. And this is actually the end of the lecture. And I want you to understand that we actually, with all the hard work, have fun in the office because we get to do work that we love, and we treat your patient, and we appreciate to have that honor. Thank you very much for being here tonight.